webinar, a broader look at lifelong preconception care. Before we begin, please note that all lines are on mute. We will have questions and answers following the presentation. If you do need to speak with our staff, you can use the questions box or the chat feature to communicate with us during the presentation. I am pleased to welcome Amy Ogle, a nationally recognized clinician, educator, and author with expertise in reproductive nutrition and exercise physiology. Amy serves as a consultant for healthcare professionals and private clients and is a guest lecturer for students in middle school through college. Regardless of the audience demographic, Amy emphasizes that the pre-pregnancy health of both prospective parents is just as important as pregnancy health. The challenge to overcome is that very few young women and men are taught the inspiring facts that support this claim. With the advent of the revised edition of her most recent book titled Before Your Pregnancy, a 90-day guide for couples on how to prepare for a healthy conception, co-authored by Dr. Lisa Mazzullo, Amy is working on exciting new approaches to reach broader, younger audiences, tapping health educators and at-risk populations. Amy lives with her husband and their 2 children in San Diego, California. Without further ado, I will pass it over to Amy. And Amy, whenever you're ready, you can go ahead and begin.
Okay, I think we've got it here from beginning. How's that look, Teddy?
That looks good. We're ready to go.
Okay.
Yep.
All right. Hi, everybody, and thank you for tuning in today. I've been looking forward to this for a long time. I will start just by telling you a story that happened the other day. Actually, let me do a little housekeeping. Would you all mind filling out a quick poll? I think that most of you are working on your bachelor's or associate degree, so if you could click on A, B, C, D, or E. If you have completed a graduate degree or a postgrad, go ahead and use D there too. But I would just like to get an idea of your academic background before we start.
Okay, I'll leave the poll open for about 5 more seconds. Okay, last chance to get your answer in.
And I'm barely able to see that, so maybe you can tell me,
so I'll
Teddy.
read it out for you. Sure. For those working on their bachelor's or associate degree, we have about 3% here in the audience. About 31% has completed their undergraduate degree, 9% are working on their master's, and 51%, wow, 51% has completed a master's or PhD.
Okay, excellent. That's really helpful. I appreciate it. Okay, well, I would like to just start by telling you a story that happened back in December. I was doing a lecture, and I was an invited lecturer at a campus nearby at Point Loma Nazarene University. And each year I go in and talk to the developmental nutrition class there. Typically the students are juniors and seniors, and we talk a lot about preconception and nutrition. And this year I thought I would try something a little bit different because there were things that made that I didn't necessarily learn as an undergrad that helped make more sense of the nutrition as it relates to reproduction. And I thought I would go over this with the students that day. And what was nice about it is the students responded really well. There were probably only about 15 students in the class, but there were 2 males in the class and the rest females, and roughly half the class came up afterwards to talk with me, and one individual really stood out. It was a young male. He was a new father, probably a returning student, and he said, you know, Amy, I always intuitively knew that my health was important for the health of my child, but I didn't know why. And now I understand why. So taking this slightly different approach where everything relates back to nutrition, but still we're talking about things that we should learn in middle school or high school or college. That approach was helpful in making this a more meaningful conversation with the class. And let me show you how I started the class. Remember, this was back in December. Coming from California, we were in a drought, we were starting to get rains and make a dent in our drought. East Coast was getting slammed, and those were big headlines. But this small headline in the corner of the paper is what sparked my interest. Now I think we're all pretty familiar with what's going on with the Zika virus in South America and the Caribbean, but it was just starting to make headlines back in January. And some quotes from various officials in the countries that are being affected were stood out to me. In particular, the public health system in El Salvador had recommended that this Zika virus and the potential risk for babies being born with microcephaly from moms who were infected with Zika during their pregnancy warranted a recommendation to not get pregnant until the year 2018. And initially I thought that this might be a typo, but other countries were following suit and saying do not conceive until further notice, or at least 6, 12, 18 months from now. So this was a really serious crisis in the making, and now we know it's here to stay for a good long while. But what also interested me from the perspective of preconception is that this was forcing a conversation in a very predominantly Catholic country and part of the world. It was forcing a conversation that was previously taboo. So what one official in El Salvador said was that, he talked about the church's view on how much control they typically like for people to have over procreation. But then he also said, but the church isn't going to say something that runs contrary to life and health. And that, just showing that there's an openness to explore this conversation about family planning and making reproductive health services more available to people was really encouraging. And the Pope later, I think a few weeks later, also chimed in and showed an openness to making contraceptives more available and more socially acceptable to people who were dealing with this serious crisis. So this was controversial. The students didn't shy away from it, though. It was a really good conversation. And I just included this slide here in case anybody would like a good resource for describing microcephaly. But what we were talking about in class was that this concept of family planning was deeply culturally ingrained as a topic that really, there wasn't a lot of planning that went on that was acceptable. But conversations were changing, conversations between couples are changing, conversations between officials are changing with the population as well. I was also interested in cultural things, patterns of handling emotions. This is going to be something that is really emotionally charged, and how were people going to receive assistance in handling these potentially traumatic situations, or at least a big change in their plans if they were in relationships where they were going to start planning soon or already trying. Culturally ingrained notions of adolescence were going to change. Adolescents are typically ones who might be more nonchalant about having unprotected sex, and this was going to, the conversations were going to need to turn more serious with them. Also, concept of past and future was going to be addressed. And this kind of taps into the concept of legacy and what type of legacy of health are we passing on to our children, and also what has our past, how has our past affected that legacy. The attitudes towards dependence and future dependence also is something that could really be addressed, and this is a potentially big opportunity to place the health of future generations in a high priority position. So all of these things are, I don't know, this is a fun graphic to use in classes if you teach students about this topic. But closer to home, we don't have Zika here, but I think we could probably all agree that there are certain crises here that we can start addressing now that also contribute to babies being born with birth defects or poorer pregnancy outcomes and maternal outcomes as well. So for one, we definitely, you know, as a dietitian, I see that in general, our dietary patterns have changed. They've evolved, and not necessarily for the better. We take in a lot of calories, but they are often very nutrient poor. And at the same time, we've supersized other things such as alcoholic beverages. The concept of what one serving is has changed dramatically over the years. And so that's a big concern for college-age kids and women and men of reproductive potential. We're also not as active as we can be. You know, with all the conveniences of modern life, we're sitting more, we're sitting at our desks, we're interacting with our devices, but we're not taking the stairs anymore. We're not, we're so busy that it's hard to fit in exercise. But you may recall that, you know, when you started out life in the womb, one of the most predictable measures of how well a baby is doing that the mom can monitor are kick counts. And that just means an active baby is generally a baby that is thriving, not a distressful type of kick, obviously, but when the baby is moving regularly in the womb, that's healthy. And it really doesn't change beyond that. We send positive messages to our body if we are using it and physically challenging it, that, you know, that it needs to be fit and ready to handle different stresses and challenges. But as it is, we are having higher incidences of young women and young men and children who are experiencing weight problems at a very young age, and addressing it on a worldwide basis has become a top priority in improving maternal and infant health and the overall health of all humans. This slide here drives the message home, to me at least, that body mass index is an independent risk factor. It's been shown to place women at a higher risk for delivering a baby with a neural tube defect. And right here, this does not appear to be modified by folic acid supplementation. So, you know, we all know that it's still important to tell all women to take 400 micrograms of folic acid prior to conception for 1 to 3 months. But I'm not sure that the message is getting out there that women with a higher BMI may not receive quite the same protection as a woman with a normal BMI, and that's really of concern. Not sure of the solution, but it goes beyond that as well. A number of congenital anomalies are associated with obesity, maternal obesity too. This is pre-pregnancy obesity. But the suspicion is that it's related to undiagnosed diabetes, meaning high levels of circulating blood sugar that are chronic and can be teratogenic, which just means that produces birth defects. And here's another thing that's making headlines of late. A lot of women are in pain and take opioids, and this continues into pregnancy as well, and a lot of babies are being born with neonatal abstinence syndrome. And when I was at a March of Dimes conference about a year ago, one of the speakers, an RN, was saying that the statistics are around 25% of pregnant women have prescriptions for opioids. And so why is it that more women are feeling the need to take these prescription drugs? Why are doctors feeling the need to prescribe them? You know, are women having more serious back pain, knee pain, and are these things related at all to our lifestyle and increasing rates of obesity? It's there's some good questions to ask and consider. Opioids also cause birth defects on their own, so, or they're at least, excuse me, they're at least associated with birth defects in offspring. So it's not just that babies are born addicted to these drugs, but there can be birth defects associated with moms who took opioids during pregnancy. So here are the different risks associated with being too heavy before conception. But I think what's important to note here is that it's not just restricted to women. This is men and women too. And here are the risks to their offspring. But we can not always expect women to lose a lot of weight prior to conception. It's not necessarily realistic, nor is it necessarily needed. If women can increase their physical activity level and start eating more wholesome diet, even if they can lose 5 to 10% of their body weight prior to conception through healthy diet and exercise, they can reduce a lot of these risks associated with the high BMI prior to conception. Fathers can reduce their risks too. I mean, look, if they are more susceptible to infections, you don't want to pass on some sort of infections, but like an STI to their partner. We don't want to have epigenetic changes to sperm. So if there's any way to at least lessen these risks, why not take the extra 3 to 6 months to lose 5 to 10% of one's body weight. Certainly more is terrific, but it's just not necessarily realistic. And then this is a discussion that we can have with all young women that, you know, if we're having a conversation about pregnancy, we can talk about when you get pregnant, that pregnancy is going to be, ideally, be 40 weeks long. A lot of women think, you know, the 9 months. It helps to look at it as a 40-week gestation, and then they can kind of gauge what they are gaining too. If a woman starts out at a normal weight, then here is what she gains during that entire pregnancy, nice and slowly, very little at first and more in the second trimester and third trimester. If a woman starts out at a high or obese category for BMI, then she still needs to gain weight for her own health and for that of the baby. But it's a much lower amount, a nice, slow, gradual process. Losing weight during pregnancy is really not recommended, even in obese women. It sometimes happens because women may have severe morning sickness for some or even all of their pregnancy, and that's a time to make sure that she gets into the doctor. She should know this, that weight loss, even in overweight or obese women, is a serious issue and not to be overlooked just because there's some extra weight to lose, quote unquote. Okay. So getting back to some of the cultural norms and roles that we play in our own culture here, I'd like to, it's nice to talk to students about what do we know, what do we just know for fact as we grow up? What do boys feel their role will be when they're adults? What do girls feel their roles will be? And a lot of the time talking with, for example, middle schoolers, a lot of the young men will think that their role starts when their partner or wife announces that she's pregnant, and then his role is perceived as one of support. So how, do we as parents reinforce these types of messages, or do we talk about, hey, when you are married, when you plan to start your family, your health will be important. Both of you need to be as healthy as possible before you start your family. Those types of conversations can be had from a young age. And then in women, a lot of the time women feel that their role starts, that they change their behaviors once they find out they're pregnant too. So again, we can reinforce that behavior change is good to at least aim for all their life, and especially if they are planning on conceiving at some point in time, or if they're having unprotected sex and could become pregnant. Okay, so this is the only slide that I'll really read everything. I'm just hoping today to develop some of these aha moments that you'll want to share with friends and other PPE audiences, hoping that we can compel people to adopt the mindset that preconception health is just as important as pregnancy health. And this is partially because we're including the man and the woman in this time frame here, but also there's so much carryover from preconception into pregnancy that it makes this time a high priority for improving maternal and infant outcomes. So, okay, I have another poll here for you. I often hear people express this as the baby acts somewhat as a parasite, with the mom absorbing the burden of anything. But the baby, will the baby get what it needs? Is it a fact, or is it fiction that the baby can get what it needs from its mom to properly develop in the womb? What do we just know?
Okay, audience, the poll has been launched. Go ahead and input your answers. You'll leave the poll open for about 5 more seconds. Okay.
How are we doing?
So about 60% of the audience believes that it's a fact, and 33% believes it is fiction.
Okay, all right, and that's those are pretty typical results, and also this is in general. So I'll talk through this, and then you'll see where I'm going with this. Think back to the last time you were on an airplane and the flight attendant asked you to listen how to deal with an in-air emergency. She always says, mom needs to, or the person in charge, the guardian, needs to put the air mask on first and let the air mask do its job by delivering oxygen to her before she can take care of her dependents. And so it's interesting, we as humans also have this need to prioritize mom. If there, for example, if there's a big pie and it's cut into 3 slightly uneven pieces, mom biologically always gets the biggest piece of the pie. She has to survive in order for her baby to survive. So the second thing that's a priority during pregnancy, at least, is the placenta. The placenta is the organ that is the go-between between the mother and baby. It's actually fetal tissue, as most of you know, but the placenta develops very early on so that it can take care of mom and baby and the exchange of nutrients and reception of waste products and things like that from the baby. Baby is actually gets the smallest piece of the pie, but it's by no means an all or nothing type of situation. If there is any sort of conflict, though, if there's any compromises that need to be made because shortages can occur, deficiencies, the mom still will get priority for what she needs before the placenta and the fetus get all of their needs. So there's a sharing, but mom does need to take care of herself first, and that's a biological drive. And this hierarchy is helpful when we look at how do we assess how healthy a woman might be when she enters pregnancy. What we look at are things such as age. We know that an adolescent, if she has recently gone through puberty, she's still growing herself, and her needs are going to be prioritized over a baby's needs to some extent. And they know this in animal studies too, that you can't use too immature of a rat or sheep to breed because their offspring have a higher risk of not being as healthy. Also with adults, a lot of adults, the older you get, the more likely you are to have some sort of pre-existing chronic medical conditions such as hypertension, high blood pressure, or high blood sugars. So we look at those things too that could affect how resources are allocated during pregnancies. We look at regular periods. Do women have very irregular periods or regular periods? And by regular, I'm talking about an average of about 28 to 30 some odd days. If periods are more than 40 days apart, then that is a red flag for you to talk with your healthcare provider about other things that might be interfering with regular ovulation. There might not be ovulation, things like that. If a woman's been pregnant before, we can tell a lot from whether she had multiples or any sort of pregnancy complications in those prior pregnancies that might affect resource allocation for a future pregnancy. And then this is a biggie. As we know that the length of time between pregnancies ideally is enough for nutrient repletion, for mom to get back down to the healthiest body weight she can, and that's about 2-year period is in general the most healthy. If a woman is starting her family at a later age, then of course talking with a physician about having a more closely spaced pregnancy is fine and maybe necessary, but we do get an idea of what her health status is like and nutrient status is like just from asking these questions. So just to reiterate, here's the drive, nature's drive, and we do have to prioritize mother's health first. This does shift a bit as pregnancy progresses, if the fetus is viable, beyond in the latter half of pregnancy, especially the last trimester, I believe that more nutrients are prioritized for the fetus. But at first, the first half of pregnancy especially, our priorities are having a healthy mother and a really healthy placenta so that baby can be well taken care of through a full-term pregnancy. That, by the way, is a great photo of the placenta from the baby's point of view. Kind of neat. Okay, so why is this picture up here? These are actually middle schoolers, and this is just to show that we can start these conversations at very young ages. And these guys behind them are even younger. So age-appropriate conversations that weave in this idea of reproductive life plan and, you know, pregnancy planning can be had with both boys and girls. And once they reach middle school, of course, those are the years where they have the talks about the birds and bees. 6th, 7th, and 8th grade are most typical times for this to progressively get more and more detailed with them. And I had the experience this year. One of my kids is a 13-year-old middle schooler, and he was learning all about gamete formation, sex cell formation. And it's amazing what these kids can memorize. They know all of the steps of sperm and egg development. They know about mitosis and meiosis and, you know, the difference between those things. So they know a lot about the steps, but when I probe, I might ask, well, okay, where is this happening? And he, you know, he was pretty good about that, a little blush, but pretty much knew that this was happening inside the testes and inside the ovaries. But when I said, okay, well, when does this happen? That's when he wasn't quite sure, and that's where I'd like to talk now about this. Let me get some of your recollections from the past, or maybe your expertise is in these. But if you could answer this poll for me, you remember a few things. To be honest, don't remember much of it, and lastly, have extensive knowledge.
Okay, the poll is up. Go ahead and input your answers. About 5 more seconds.
And go ahead and, you know, even if you don't remember it perfectly, just give your best guess. It's not being graded.
Okay. So about 80% of the audience has answered, so we'll go ahead and close it. So Amy, we have 29% that have answered yes. 27% don't remember much, and 44% has knowledge of the process due to higher education.
Okay, good. And then one more just to complete this. After puberty, we know that males continuously are making fresh sperm. So what is the typical lifespan of a sperm? And if you don't know, just go ahead and take your best guess what would make sense to you.
Okay, audience, that poll has also launched. Please input your answers.
A typical lifespan of a sperm. They are making millions of these around the clock. What's their lifespan?
All right. Couple more seconds. Get your answers in. Okay. Poll is closed. 4% answered about 3 minutes. 13% answered 3 hours. 68% answered 3 days. 11% 3 weeks, and 4% 3 months.
Okay. So this is actually, this is one of your big aha moments for the majority of the audience. It's actually 90 days or 3 months for full lifespan of a sperm. Let me show you. This is what is so exciting to me, and this is why when we were writing our book, we devoted an entire chapter and weaved this message throughout the book, that men are just as important as women in their sperm formation. It takes a full 90 days for them to make those sperm, and then they can store them for 2 weeks in the testes, in the epididymis, which is like a waiting room. But this process here of meiosis, where we are getting, we're starting with an immature sperm cell, we're creating the genetic code that will be delivered to, that will be carried in the sperm, and completing 2 division cycles. This is all taking about 10 weeks, and then the storage occurs for about 2 weeks. So this is really, really exciting to most men to know that, oh my gosh, my role is not just the night of conception and then as support later on. The role of for them is right for those full 3 months or more before conception. Let me show you. Okay, here we go. So really good overall nutrition and good health for men during the entire period of spermatogenesis and sperm formation or sperm storage is critical. So we need at least 3 months to resolve any sort of pre-existing health conditions. It's just a good time to have a squeaky clean lifestyle, and for women to not think that all of the responsibility is on them. They share this responsibility, and it's empowering. It can be a time for couples to work together towards a healthy conception. So it's not a negative thing, and it doesn't have to be a honey, you need to do this type of thing. It's give them the information, encourage them and set them up to succeed, and then they can do the same with you. Encourage each other to succeed during these months prior to conception. Part of his role too during this time is to make sure men and women are comfortable in the grocery store, in the kitchen. Men need to know how to handle food properly, make sure that there's no handling of food that can cause foodborne illness, because if a woman conceives and is pregnant and has severe morning sickness, the last thing she wants is to have food poisoning from her spouse that's trying to take good care of her. So that's a pretty big deal. And then, of course, role modeling for the future. Prior to pregnancy, it's so much easier to change any sort of lifestyle habits because there's too much of a learning curve once the baby comes and once pregnancy occurs. So doing this all now and then being able to model for later on is much easier if begun before conception. Okay, so let's look now at the lifespan of a human egg inside the ovaries, and here are 2 hints. So there's a baby inside here. Let's say that this is a female baby, and some of you will know or have heard that girls are born with all the eggs they will ever have, right? So that means that this baby, when she was inside her mother's womb, by the time she was ready to be delivered, she had all the eggs she would ever have. And this is how it works here. Okay, here we go through meiosis again, which is getting to the haploid number of chromosomes, 23 chromosomes, so that it can pair with the other 23 chromosomes that are provided from the father's sperm. So what's happening here is the first part of development for an immature egg is to duplicate the DNA, and then there is a lot of swapping of information between the paternal and the maternal side, so that we get a brand new genetic code basically that will be in the egg that becomes the primary egg to be ovulated. So what's interesting though is that once this happens, once the genetic code is written, that egg basically freezes. I mean, it just starts, it just stands still, and it does not do anything else. It stays in this suspended state of division. Sorry, where's my pointer? There we go. It stays in this suspended state of division until this part of her life. And so the last stages of meiosis don't happen until ovulation and actually right upon conception. The last part of this egg development takes place. So this all happens. If this was, let's just say this was you. Let's say this is the egg that made you. This was in your biological mother's womb, right? Or it was in her, I'm sorry, it was in your mom's ovaries when she was in your grandmother's womb. So basically, this genetic code was written when your mom's eggs were inside the womb of your grandmother. And again, that's one of those things, I hope that makes sense, and I can try to describe it again if I need to towards the end, but it just to me shows what a legacy we have from our ancestors, and also what a big role we can play in the health of future generations if we do things to try to reduce the risks to egg formation and sperm formation. But this is a long life cycle. This starts out in the womb and ends upon conception. So you can say that a female egg life cycle is anywhere from, what, maybe 13 years to 40 plus. So that's a long time. And the environment, her internal environment and external environment can influence this for a long time, both positively and negatively. I like to focus on the positive if we can, so let's do that. I think one of the things that PPEs are taught is that it's interesting that maternal mortality and infant mortality statistics are often better in immigrants in the first, maybe second generation that they're here. And so does some of this legacy business come into play with why statistics might be different? I think it's a good question to ask. Okay, and then this slide just very nicely recaps all of this, that sperm development happens, takes about 10 weeks for spermatogenesis. They're stored for another couple of weeks, and so in total that's about 3 months, and then the egg kind of awakens and comes out of this suspended phase of division around 3 months before conception, or before ovulation and possibly conception. So the 3-month period for both prospective parents, the biological parents, is really critical for their health. Okay. So let's look at this more carefully now that conception has occurred. Sorry, my mouse is being a little bit fickle here. So here we go. I'll orient you. This is the egg, the ovary, and it's just released, ovulated an egg. Sperm travel through the vagina into the uterus, through the fallopian tubes, and are fertilizing the egg right here. And then it takes a few days for the zygote to travel through the fallopian tubes and make it back into, or make it to, the uterus, where once it's a blastocyst, it is going to implant inside the uterine wall, the endometrium. And what's required there is a very robust immune response and hormone response. Our immune systems are not gearing down. That's kind of another fiction. We need a nice, robust immune response to create a really strong anchor for the blastocyst to implant. And this is where the placenta starts to develop too. So a whole system of vascular remodeling occurs right here. And guess what happens to not all women, but to some women when this implantation occurs? Some women experience what's called implantation bleeding. And so this is always very, you know, every gal in the classroom when I'm talking about this knows, okay, what do you think? You think you've just gotten your period. Well, indeed you haven't. This is just a sign that implantation has happened that not all women experience, but you don't want to mistaken getting your period when you haven't, because you know you might go out to that wedding reception or to the tailgate party and think, oh well, I just got my period, it's a light one, but I'm not pregnant, so maybe I can party a little bit more than I thought I was going to. So something to pay attention to and be careful of. What's also going on during this time is there's a lot of communication. What's this intrauterine environment like? How hospitable is it? And what kind of anchor can I create? How long should this pregnancy last? Is the body ready to carry a baby for 40 weeks, or does it look like it might not be best for the mom's sake to carry a baby to full term? Maybe the baby, maybe the placenta needs to be given a warning that this pregnancy might have to be delivered early, might have to end early. So again, having a really pristine intrauterine environment with healthy immune system, not too much inflammation, all those things go together. Good blood pressure control, anything that could impact something negatively here needs to be taken care of prior to conception, and that will help show that this is a pregnancy that can go the full 40 weeks. Okay, this is, I love the title to this study. Boys live dangerously in the womb. This is something that Kent Thorberg from Oregon Health Sciences introduced to me. He was saying, you know, boys, they go for growth. They're thinking, well, not thinking, but you know what I mean. When boys are in the womb, they aim for a faster growth trajectory than girls do. They put less of their resources into their placenta and more resources into quicker growth in the womb. It's very small difference, but it is significant. Girls put a little less emphasis on fast early growth, and they put more of their resources into their placenta. So what happens is, it's great if there are plenty of resources, but if there is a shortage of nutrients, then the boy babies end up paying a bigger price. And sometimes this doesn't show up until much later in life, but there are some medical conditions that, you know, if you think about it, sometimes boys are a lot more prone to developing certain medical conditions than girls. And some of that can date back to their intrauterine environment. There might have been some nutrient deficiencies that impacted this growth strategy. So our genes can tell us how we need to grow, and that, you know, the timing for development and all of that, and everything is programmed in this gene code. But our environment also will help dictate what actually happens with for outcomes. So our first environment is the intrauterine environment, and we want it to be nice and healthy. This just shows, I'm sure you've probably seen some of this before, but I like this diagram and I use it for students because it shows how early things start. We've got a heartbeat by the middle of the 3rd week of pregnancy. So here's conception, and then organ systems start developing right in here. Okay, so this is week 8. By the end of week 8, most women know they're pregnant, but certainly not all. But all of this organ development is taking place often before a woman even knows she's pregnant or before she sees her physician or healthcare provider. So another good reason to have all the resources available for her body to nurture a baby from, you know, from day 1. Okay, here's where the neural tube forms by the end of the 4th week. That's closed. So very, very early on. And also, I think we remember that, may know that heart defects are the #1 birth defect. And look how early they can start. So here it is in a nutshell. Let's try to create this paradigm shift together that both men and women need at least 90 days of optimal health before conception occurs. And even though women have taken the lead here for a long time, it's still something that I think if men know how important their role is, they'll be a lot more, I think that they'll be a lot more willing to make some lifestyle changes long before conception occurs. And finally here are just, these are the objectives that I set out for today's webinar, and I hope that I've driven these messages home, and the legacy message is fantastic, and then also encouraging better access to reproductive health and pregnancy spacing of 2 years or more. Okay, so that's it. If there are questions, I'm happy to answer them, and you've got my email address here as well, and website address. But feel free to contact me if you have questions that I'm not able to answer after today's webinar.
All right. Thank you very much, Amy, for that great presentation. We have a few questions in the questions box. Audience, if you are interested in asking Amy any questions, please check the questions window on your control panel. So we'll start with the first question for you, Amy. Actually, it's a few questions combined because they're basically the same question.
Okay.
You mentioned class, or when you teach class, a number of times. What age groups are you teaching? And the second part of the question is, you mentioned the egg cycle begins at 13. Do you recommend starting early with girls, teaching them about preconception care, maybe combining it with reproductive education as well?
Yeah. Well, okay, to answer the first question, I'd say I talk primarily to college students, and I've just started doing some of the PPE lectures as well. So those are generally college-age students. But I also am really in favor of starting these discussions with middle schoolers. We can talk about some of the same things that we talked about in this webinar with middle schoolers. Boys and girls that are of that age are very interested in pregnancy. You would think that boys aren't necessarily interested, but they're very curious about pregnancy. And it doesn't make them want to go out and have sex or anything like that. Sometimes why schools shy away from talking about this in a school setting. But if anything, talking about preconception and their role, and talking about pregnancy too, and just what happened, you know, what women feel and what goes on during pregnancy, makes them realize that it's a big, big responsibility, and that it is something they need to plan for eventually. Even if they don't want to have, you know, a lot of kids don't know if they want to have a family someday. In fact, some are very adamant that they don't want to have children. But when you give them the statistic that half of all pregnancies are unplanned, that means that half of them in that classroom will have an unplanned pregnancy, whether they want to or not. So it is a good place to introduce it. And secondly, with the egg cycle, that, you know, the egg cycle begins when that baby girl is in the womb. So her ovaries are developing. That first part with the DNA, the genetic code being written, that happens when she is inside her mother's womb. So that is where the egg cycle starts, and then she goes through puberty and starts to ovulate. So that's the, you know, the picking up where it left off happens right at puberty, and then every month thereafter if she's having a regular cycles. So yes, I think it's a great time to introduce all of these concepts and tell young women about the about sperm development as well as about their own egg development. They need to know both, and the young men too. They need to know about what's going on in women's bodies. Sometimes we don't help each other because we're, well, what am I trying? I think sometimes men and women sabotage each other's efforts to take really good care of themselves, and it's not necessarily on purpose, but if there were more rationale for helping each other take care of themselves their whole lives, and to convince ourselves to take care of ourselves for our whole lives, it might, I think we'd all be better off, and we wouldn't have quite as many risks. So. Go ahead.
Okay,
sorry.
Sure, thanks, Amy. Another question, this is for health workers and PBEs working in areas with food deserts. What advice can you give them? What advice can you give them on sharing information to reduce maternal and paternal risk in pregnancy?
Right. Well, I mean, I know that there are a lot of cities that are addressing the issue of food deserts, and I don't have some of the model programs right at the tip of my tongue. I think, Philadelphia might be one. I can get that information for you. There's a lot going on in the field of childhood obesity, especially because they want fresh fruits and vegetables and high quality proteins and things to be available in these areas where there is a lack of variety and fresh foods for people to buy. So I do think it is something that we're working on, but then once it's there, for people to actually buy it and try it, make a big deal about, hey, let's try this recipe and prepare it together. Or another example is, if you're used to eating almost all processed foods or takeout foods, at least buy a little less of those things and then supplement them with something fresh that is delivered to the local grocery store. Because there are a lot of places that are trying this. They just need to know that you'll support them if they bring it in. So I can also try to share some other resources that I can gather from my files after the webinar as well. Does that helpful? I think there, YMCAs and other places are, I know that there are several in town. We have several places that offer cooking classes, and there are food pantries, of course, that offer a lot of fruits and vegetables that are fresh, WIC programs that have vouchers for farmers markets and so forth. So there are an increasing number of resources, but it's still a big issue, as is the issue of safe places to be active and to take our kids to be physically active as well. But in that case, you might need to just make sure to take the stairs at your workplace or the stairs at your apartment instead of taking the, just the habit of taking escalators and elevators everywhere. So both food and activity are things that can be addressed in small ways before the big changes are available. But it's a really good question, and it's something that's being addressed.
Right, thanks, Amy. That is a really good question. And if you would like more information, Amy's email address is on the screen, but you can also contact the Office of Minority Health Resource Center at info@minorityhealth.hhs.gov. So, Amy, our next question, can you clarify birth spacing? Specifically, you mentioned 2 years of birth spacing. Can you clarify what that means?
Yeah, from one pregnancy to the next, the ideal amount of time that's healthiest for mom and baby is 2 years time. I think it used to be more like 18 months to 24 months, but the standard now is to recommend 24 months between pregnancies. Now, if you think about it, this will give the mom time to breastfeed her infant for a year, even longer if she wants to. And also, as the pregnancy goes on, and with childbirth, there are other, blood losses and nutrient losses. Some nutrients take a lot longer than others to replenish. If a woman is anemic, it can take months to get her iron stores up to par. So she wants to enter pregnancy again with good iron stores. Different omega-3 fatty acids often take at least a year to replenish, if not more. And there's not a lot of research on that, so that's just in general. A lot of things take time to replenish and give the baby the best outcome possible. So, but that's definitely I think the World Health Organization came out with the latest recommendation on that one. If not all, I think pretty much all the agencies are on board with 2 years between pregnancies, except for women who are of advanced maternal age. And in those cases, being very, very healthy, and needing to have pregnancies a little bit more closely spaced to, avoid avoid problems with infertility potentially. Some women will be able to have closer spaced pregnancies there, but that's got to be on an individual basis. It's a good reason to talk about contraception right after delivery. So. That's where WIC and other agencies can, that 6-week postpartum visit is a good one to talk about all of these things, and the 6-week postpartum with your primary or your OBGYN can be very helpful there.
All right. This next question is on obesity and folic acid. What are your thoughts on obese or overweight women? What are your thoughts on the recommendation that obese or overweight women take 800 with micrograms of folic acid instead of 400?
Yeah, that's definitely something that's been proposed and that some people are already recommending. I personally am not. I don't really advocate that as much as trying to get the 400 micrograms of supplemental folic acid plus a lot of good dietary sources of natural folic acid, because there is an upper level of recommended intake for folic acid, and that's 1,000 micrograms. So I just personally don't like exceeding those recommended limits, and it happens very easily because if a supplement has 800 micrograms and then the woman's eating fortified cereal and fortified bread and all these different foods that have the synthetic folic acid, she is definitely going over the upper limit for synthetic folic acid. There is no upper limit for natural forms of folic acid, which are found in leafy greens and lentils and a variety of foods. So that's my recommendation, although there is no consensus at this time about how much folic acid might be necessary for obese women in supplemental form. I think the jury is out.
Okay. We're going to take a few more questions. This one is similar to the first question, but a little bit of a twist. You mentioned that mom needs to take care of herself first. You've also mentioned that women have all the eggs they will ever produce from birth. So when do you recommend starting preconception care education?
Well, I mean, ideally from a really young age. I guess the the context, it's a semantic difference. I think sometimes when I was growing up, I might have heard the conversation, when you grow up and become a mommy, or that that type of conversation when I was very, if you become a mommy someday. But I think with young kids, we can start it very early by saying, when you plan, when you grow up and when you plan to start a family, just by tweaking, you don't just become a mom, you plan to become a mom, or you don't just become a dad, you plan to become a dad, and you do things that are healthy for your body all along if possible. But nobody's perfect, and nobody lives a squeaky clean lifestyle their entire lives. And we know that babies are born from moms who haven't had the easiest time taking care of themselves, and dads too. But I think we can just we can insert that word, when you plan to become a parent or start a family. That's probably the best way you can start talking about it with really, really young kids. And just talking about reproduction with similar age-appropriate wording can be done. You have to get creative about it. I mean, I use what's another? I mean, I like to talk about the intrauterine environment being kind of like a construction zone with kids who are in middle school, for example. And if you have a construction zone, you want to make sure that you have all the materials that you need to build that structure, the home that's on the blueprint. You've got the blueprint. You're required to build this, but you want all the materials that you need to be there on time and also to be organized. You don't want 10 times the amount of materials, because then you're going to have to put up blockades to, keep these out of the way so they don't confuse the work site. You also don't want to have to deal with shortages on materials for this construction site either, because you still have to go by the blueprint, but you might have to short something somewhere. So, that type of discussion can be had with pretty young children, and then later build on it and let them know that this happens, this happens in your own body. This is, it's just a different way of talking about it. So I think everybody out there is creative, and they can do this in their own way with very young aged kids through adults. I mean, it's fun for adults to think about analogies as well. So it's a fun thing to do with students of all ages.
Thanks. And Amy, where can we find your book? I know you have it on the slide, but it's chopped off at the bottom for those interested in purchasing your book.
Oh, well, Lisa and I have a website that is www, and then just spell out beforeyourpregnancybook.com. It's available at all bookstores, and it's available as an ebook. We actually, our copyright date on the book is 2011, but our publisher, Random House and Penguin, they just recently merged. They actually allowed us to do some updates to the book in 2014. We made about, I don't know, 50 or so updates to the book. That it couldn't be anything that changed the layout of the book, but so it's up to date through 2014, even though the copyright date says 2011. But it's available everywhere. And I'm happy to take, go ahead, sorry.
No, we just had one more question, but go ahead, finish, please.
Oh no, I just, if anyone has trouble finding it, or you wouldn't, I mean, it is available, but you can always contact me offline as well. So.
Okay, and lastly, I try to get all of our peer educator questions in. Okay. So what advice can you give our preconception peer educators who are working with their peers on college campuses. What kind of advice can you give them on relaying the message of the importance of preconception health on their campus?
Well, I have not personally seen all of the materials. I haven't seen all the PPE materials, but when I first saw the PPE display at this March of Dimes conference over a year ago, I noticed that you've got a lot of excellent resources that the Office of Minority Health has developed. So first would take advantage of that, but then take it a step further and maybe use some of this information in the webinar and create posters. I even tried to draw it's not in this webinar because it failed, but anyway, I even tried to draw what it would look like if you had a baby representing you, drawn in a quarter, and this is an infant, and then drawing a picture of a woman with that same baby in her womb, and then also drawing the grandmother with the mother in her womb, just to kind of show that these eggs have, they have some history to them. There's a little bit of all of these prior generations in them, and I would like to see somebody do something really creative with that. Also, this is something that's really fun and you could certainly do. There's a terrific mathematician in town called, his name is Alex Kajitani, I believe that's his name. But anyway, he's called the Rappin' Mathematician, and he's done all these great rap songs about math. And quite a while ago, I tried to work with one of the bigger organizations to develop a preconception rap song, and Alex and I got together and we tried, he showed me this downloadable program that you can make your own rap songs. And so we did this rap song, talked about 90 days before conception, and it, I'm not going to do it justice right now, but we inserted some of the messages into that, I don't know, I think it was about a minute and a half rap song, and it was fun. And you can do this and you'll sound really good if you use the computer program that makes it. So that's something you could do at a booth, and it would be very quick and easy to do. So I would love it if somebody would come up with a rap song about these different points, of how to take care of yourself prior to conception.
Okay, PPEs, you've been challenged. So that will conclude our webinar. Thank you so much, Amy, for sticking around to answer these questions. Thank you for your presentation.
You're welcome. Thank you, everybody, for joining.
For sure. I'd also like to shout out Dr. Susan Jatan and the California Baptist University PPEs. They are the ones that reached out to Amy and suggested that she do a webinar for us. So thank you to the Cal Baptist PPEs as well, and Dr. Susan Jatan. Again, thank you, Amy, for your presentation. And what's the best way to reach you for our attendees if they have further questions?
Through my email. As you know, I'm not on Facebook yet, so this is definitely an impetus for me to get on that. But definitely the best way to contact me is directly through my email, and I'm happy to talk with people. In fact, I'd like to know more about the people who are attending these webinars. It's just, when I started this 20 years ago, I felt like a Lone Ranger out there talking about the importance of preconception, and you wouldn't believe the comments that I got from any number of healthcare workers and physicians mostly who didn't see their patients as potential, audiences for this type of discussion. And it's really changed and it's very exciting. But I'm interested in who's part of this audience. So please do contact me. I'd be happy to talk with you.
Okay, great. Please contact Amy via her email. A recording of this webinar has been recorded, and the recording will go out in about a week for all of you who registered and attended, and as well as for those who registered and couldn't attend. You will receive a link to the recording. You can also check us out on the Preconception Peer Educators WordPress, and you can check out the video archive on the Office of Minority Health YouTube channel as well. Again, thank you, Amy, and thank you all for joining us today. This concludes today's webinar.
Thanks, Teddy.
Bye.